I'll introduce you. And then you
Okay.
can kind of introduce yourself.
Okay.
Welcome. I think we'll get started. I imagine that since it's lunch, people will be kind of coming in and out. Hi, Jerry Halverson, Medical Director of Adult Services at the Oconomowoc campus. And what I'm here more specifically representing today is Medical Society and Psychiatric Association. I invited Rick Abrams, who is the Medical Society's new CEO, to come and to talk to us a little bit about his experience, and then we'll kind of talk about what's going on right now as far from the organized medicine perspective, all of the regulations and all the stuff that are going on that you probably don't know about. You should at least know what we're working on behind the scenes, and we'll go from there. As I said, I want to introduce Rick Abrams. He is the CEO of our Medical Society. We hired him in April. Boy, about 6 months ago, if I can do math quickly. We were able to get him from New York, and I think he'll tell you a little bit about that. And then after he's finished, we'll get started with the update.
Okay, thanks, Jim. Good afternoon, folks, and everyone on the camera or on the phone. My name is Rick Abrams, and I am the Chief Executive Officer for the Wisconsin Medical Society. And I just want to take a couple minutes before I throw it back to Jerry to talk about issues, just tell you a little bit about myself. I was born and raised in New Jersey, so I'm an Easterner. I'm a lawyer by training, and I graduated Seton Hall University Law School in 1982. And since 1982, I've held positions both within government and outside of government. The first 7 years after I graduated law school, I worked for the administration of Governor Tom Kean in New Jersey. And I started my career in healthcare in 1987. I was Director of Government Relations for the New Jersey State Department of Health. And my second and last job in the administration, I was the state ombudsman for the institutionalized elderly. And the ombudsman's offices, there's an ombudsman's office in every state, including Wisconsin, and really they're advocacy agencies for patients and residents who reside in long-term care facilities. And that experience was a great one simply because it really, put me on the ground with providers of healthcare and professionals who provide healthcare. But also a very, very unique issue with New Jersey is that our office was responsible for all proposals to withhold or to withdraw life-sustaining treatment in long-term care facilities. And that really sensitized me to the whole issue of advanced care planning, and certainly one of the connections that I was able to make, and one of the reasons why I wanted to come to Wisconsin, really is because of the focus that the Wisconsin Medical Society has in advanced care planning. Left the administration in 1990 and really started a career in long-term care delivery. I was the lobbyist for and ultimately the CEO for the trade organization that represents facility-based long-term care in New Jersey, primarily back then nursing homes. And then from there I worked in Washington, D.C. for 4 years with the American Healthcare Association. 2004 I started my career representing physicians, and I went to work and held a similar position with the Medical Society of the state of New York. And folks, the last thing I'll say, just by way of introduction, is that there's both personal and professional reasons as to why I wanted to come to Wisconsin. First, from a personal standpoint, I love the Midwest. I'm a University of Minnesota graduate. Graduated, I played a year of junior A hockey in the middle 1970s in Austin, Minnesota. And when I got down, when I had the sense, I guess, knocked into me to get my education, one of the schools that I applied for transfer to was the University of Minnesota. And I got in there and I graduated from the University of Minnesota in March of 1979. And in fact, if I would have gotten into a law school in Minnesota, I never would have left the Midwest. Now, a lot of great things, like my wife and my kids, have happened to me when I had to go back east. But, if I always knew that if I ever had an opportunity to get back to the Midwest, that I would investigate it. And sure enough, around December of last year, I found out that my good friend Susan Turney was leaving the Wisconsin Medical Association, and I applied for the job, and lo and behold, they hired me. So from a personal standpoint, and I'm happy to say that both I and my family love Wisconsin. We settled in Madison, which is where the Society's headquarters is, but we love Wisconsin. So from a personal standpoint, it's a great decision. And I absolutely feel that way 6 months into the new job. From a professional point of view, you know, what you need to understand, and maybe you do, and I'm sure you do, is that Wisconsin is an extremely progressive state. And I believe firmly, especially in being able to compare my experience in Wisconsin with my experience in New York, I believe firmly that Wisconsin has positioned itself tremendously well to get ahead of change in both healthcare delivery and healthcare payment. And let me just very, very briefly illustrate. In New York, I had to worry about the internal operations and the external public policy, which is where my expertise is. But in New York, I was supposed to spend almost all my public policy time fighting with everybody. So I would spend a third of my time trying to achieve a cap on non-economic damages for the doctors and the hospitals in New York. Well, in Wisconsin, you solved that problem 10 years ago, and unfortunately, I had to solve it again about 7 years ago to pass the cap and have it signed into law. The second third of my time I would spend fighting with insurance companies rather than working with them. As I was saying in a previous meeting, you know, on Tuesday I would poke United Healthcare in the eye, and on Thursday they would poke me back. And we would both think that maintenance of status quo was actually progress. It's not progress, it's the maintenance of the status quo. And the third thing I would spend my time doing is fighting with all of the other medical professions. So we would fight with the podiatrist over scope of practice bill, or the chiropractors, or the nurses, or the psychologists. And sure, you know, there are going to be disagreements among the healthcare continuum. But, you know, I guess my point is that, so I come to Wisconsin, and like I say, probably the most amazing thing that I found since I've been here is that before I got here, I read about it. But when I get here, you know, actually you all are really doing the kinds of things that I want to do for the remainder of my professional career. So let me give an example of what I mean. Is first, you know, we all work together. And again, sure, there's disagreements, and I think they're healthy. But, you know, we all work together. So the doctors work with the nurses and the hospitals and the health insurers and the employers and the insurers to try to solve problems. That's a really, really healthy thing. You know, and from a public policy standpoint, the kind of issues that I spend a lot of my time on are issues that move the proverbial ball down the field, don't just make sure that things don't get any worse. And again, you know, just to illustrate, I think the whole issue of advanced care planning, absolutely important, not only for the benefit of our patients, but also as a practical matter, it saves money. So we're using our healthcare dollars a little more efficiently. The whole concept of creating a claims data warehouse through the Wisconsin Health Information Organization, and then more importantly, not just creating the warehouse, but trying to do something with that data, again, for the right reasons, to try to enhance quality and try to reduce the cost. You know, those are the things that I want to spend the last 10, 15, 20 years of my career doing, and we're doing it in Wisconsin. So that is probably a longer introduction that you wanted, but I just wanted to give you a little background about myself, but more importantly, why I decided to move from New York to Wisconsin. So with that, let me turn it back over to Dr. Halverson, and then we'll talk about some of the specialty-specific public policy issues, and then if we've got some time, I'll be happy to address the more omnibus issues at the state and federal level. Joe?
Great, thanks, Rick. So yeah, we'll just kind of launch in, and as you know, most of you probably know, the reason that I know this information at this point, and you don't know this information, is because I'm. Is that moving? All right, that's not moving. Is it moving over on the other side? Over in
Yeah. Yeah, it is.
Is it the where I'm coming from slide? Got for you guys? Okay. But I will, you know, again, let you know, how do I know this information? You guys don't know this information. I'm obviously very involved in the Medical Society and the Psychiatric Association at the local level. So we're all members of our county medical society. And it's depending on where your primary work site is. The Medical Society membership isn't where you live, it's where you work. Since I'm working both in Madison and Waukesha, I have a full membership of both Waukesha County and Dane County. Now, everybody here would be Waukesha County members. Folks that are practicing in Milwaukee are Milwaukee County members. Now, your hospital, whether you realize it or not, hospital pays your dues. You guys are members right now. So I am a past president of the Dane County Medical Society. There we go. I am on the WMS Board of Directors and I chair the Council on Legislation there. I'm the Psychiatric Association president-elect to be president in just a few months and the chair of legislation there. So that's where I'm kind of getting the knowledge of a lot of the local stuff. And I am a member of the Legislative Council for the APA also. And I also represent our specialty organization in the AMA House of Delegates, which is the policy-making body for the American Medical Association. So that's where I got this. And really what got me interested in being more active in the medical society and trying to put something on like this to kind of let you guys know what your dues are paying for and what organized medicine is doing for you is really right now psychiatry medicine is getting very complex and there's a lot of things that you have to worry about at the point of care, and there are a lot of things going on in the background that you're probably not worried about, you're not thinking about, and that's because WMS and APA, this is why we have your back, and we're trying to make it easier for you to be able to practice medicine without having to worry about all this other stuff. Now, if you're really into policy and enjoy advocacy, you certainly can be as involved as you want, and we can talk about that a little bit later, but obviously we're doing this stuff so you don't have to. So let's first start at the federal level. National level issues include healthcare reform, and I'll break these out a little bit. Healthcare reform, essential health benefits, which we'll get into. It comes from healthcare reform. Workforce issues, reimbursement issues, parity, psychiatric system funding, DSM-5, billing, and maintenance of certification. Those are all things that I'll just mention very briefly. We can go into more detail about any of this stuff. We probably don't have time today, but certainly I'm happy to discuss any of this stuff with anybody at any time. Healthcare reform, as you know, it was upheld by the Supreme Court, but really a lot of people are waiting to put its tenets into place, and at least some of them, particularly at the state level. Folks are waiting for the election. Certainly, if the election nationally goes one way, implementation will be much slower than if it goes another way. So right now, healthcare has been upheld, and a lot of it is already going. But how ultimately it's going to get paid for and how it's going to be put in place is pending the election that we have coming up soon. So again, that's an important election. If you're supportive of it, you probably want to vote for one guy. If you're not, you probably want to vote for the other guy. How is the Affordable Health Care Act going to affect us? It's going to affect us in many ways, as you're hearing. There are less insured, there would be less insured. Again, how that is being paid for, who is paying for that insurance, and what level of insurance these folks that were previously uninsured have is still to be determined. There's also, you'll hear about pay for quality. Right now, one of the things that's being demonized in medicine in general is, docs make more money by seeing more patients, and there's this belief that if we pay docs for higher quality, meaning better outcomes, that's a better way of paying for it. Right now, particularly in psychiatry, although you can say this about all subspecialties, nobody has an idea really what quality looks like. I could tell you what I think quality is, and you guys might have different answers for what quality is. And I think that's part of the concern, and we can certainly take a much deeper dive into that at some point as far as quality measures and that type of thing. And certainly happy to talk to you about that at a later date. Also, integrated care. Is something that you'll hear a lot about. I know, Rogers, we're looking at how we can take what we do and bring it closer to primary care or make it more easily accessible to primary care, but that is still a big to be determined. And I'm not sure what I was saying with as. I'm sure it was very, very important. I'm sure it was very important. But I do want to spend a little bit more time with essential health benefits. Essential health benefits is what the folks that haven't had coverage before are going to have, and I think there is some concern that once we define these essential health benefits, the other types of payers are going to start offering maybe just this. So there is a lot of concern about what goes into the essential health benefits. Essential health benefit is what has to be offered by an insurance company. Now, it is covered by parity. you have to offer some sort of mental health and substance. The mental health and substance has to be offered at parity to medical issues if you're offering mental health. And the feds are saying that you have to offer mental health, so it will be offered and will be offered at parity. But as we know right now, what does parity mean? Again, you have the benefits, but you don't have access to them. That's, in our experience, at least in my experience, and I'm sure the experience of a lot of people here, you know, that you might as well not have them. So who is going to set up what is an essential health benefit? As Rogers, we've already been to the Office of the Commissioner of Insurance, kind of figuring out who is going to set this up. Clearly, we would like there to be partial program coverage. We would like there to be residential program coverage as far as psychiatric disorders are concerned. But it is not clear who's going to make that decision. The feds are leaving it to the state. The state is waiting until November, although really a lot of the homework was done by the Doyle administration. You know, it's something that can be pushed forward rather rapidly. But it's probably going to be a legislative fix is what we're hearing now. It won't be coming from DHS, won't be coming from the Department of Health Services, won't be coming from the Commissioner of Insurance. It's probably going to have to go through the legislature. And at that point, that is when Rogers, WMS, WPA will be more active as far as helping to shape that benefit. Other issues, and I'm not going to go through this at all, but obviously if you've been paying attention, ACA is a lot more than quality and you know, it affects us a lot in a lot more ways than essential health benefits and quality. One of the things specifically I know that Rogers is concerned about, and I think everybody is concerned about, are the accountable care organizations and how Rogers fits into that, and how a standalone psychiatric facility. The accountable care organization, the idea is that it's basically a bundled payment. You have a entity that takes responsibility for a complete episode of care, and then that entity decides who to pay what. And if you're an external organization, or if let's say this is a hospital that does not have psychiatric services, which, as we know, many hospitals do not have psychiatric services, it will be up to them to decide which psychiatric service to contract with, and then you have to figure out how to get paid from that perspective. So there are a lot of questions with that. And there are also the Physician Sunshine Act. If you know what that is, that's basically why if you go to a pharma lunch, that's going to show up on a website somewhere, so that there is some sunshine to that. And there's also many other things. I do also want to talk a little bit about healthcare technology. There had been some stimulus money other than going to mental health. Mental health has been left out of that. So mental health in general is behind the 8 ball on electronic medical records and those types of things. Workforce issues is another big issue moving forward. Basically, how can we see the patients that need to be seen? How can we as psychiatrists be there and give our patients the quality of care that they need? Moving forward, assuming that the ACA moves forward, there's more people with health coverage. Certainly, we're having more complex, vets are a pretty big issue right now. More people are coming back with PTSD, more people are coming back with traumatic brain injury. Those are folks that are really going to need to see psychiatry versus nurse practitioner or whatever. And at the same time, we are facing drastic cuts to graduate medical education. So there will be probably less residency slots available moving forward. So having to figure out how to still meet our duties to see the patients that need to be seen is something that is frankly worrisome right now. And again, we've known that as baby boomers age, as there are more people, there is going to be more need for psychiatric consultation, but with the ACA, more people, more consultation. And looking at the numbers, projected shortfall, general psychiatry, about 40,000. So, a child and adolescent psychiatry and geropsychiatry get a lot of the pub, but just general adult psychiatry is also going to be something that's going to be a shortage. So it's something that we really have to consider. Medication shortages are something that we're also active at the national level. You guys are aware of this, particularly if you're using stimulants, I don't know, Naltrexone, anything. Particularly the stimulants that there hasn't been access to some of the stimulants, and a lot of that are kind of federal regulations regarding how much of this can be out there at a certain time. And as people use it more for depression, there are more kids getting diagnosed with attention deficit. There isn't enough of it out there, so we're working on trying to make more of that available. System funding continues to be a big deal. The first thing, one of the first things that get cut when state budgets get cut or local budgets get cut are the resources for our patients, because our patients are oftentimes the ones that are kind of surviving on the periphery as we move forward. So that's something that we continue to push for. You know, the feds now give a lot of their money as far as grants go, and historically I've been on the Mental Health Council for the state, and what we do there is we give out grants. We've generally been giving out grants not for face-to-face care because there have been enough county services or state services to cover that. We've generally been giving out those grants for novel approaches to suicide or best practices, but as the local funding gets cut, those are being more used for patient care grants, and those will also be cut as we move forward. Parity, as you know, continues to be a problem. We have the legislation. It is out there with some policy behind it. The problem is that the government is not really enforcing parity, and that's something that we're continuing to push the government to do, is enforce parity. I think each one of us in our practices have had have questions about some pretty obscene parity problems, and that certainly happens in different parts of the country. Florida actually had one of the large insurance companies carved out mental health again, and you had to, if you were going to provide services for your patients, you had to go to this new carve out and take a much lower fee, and that's something that really with parity shouldn't be happening, and the APA and Florida providers did rise up against that, and it was kind of called out. But certainly the insurers are pushing the limits. DSM-5, as you've probably heard, is going to be rolled out, assuming that it's approved in November, which it will be approved, is going to be rolled out at the annual meeting in May. How we're doing this at the WPA is we are going to have, there's a train the trainers meeting in May at the annual meeting. We will be taking some folks, sending them to the train the trainers meeting, and then we will have different events around the state for training, not only for our members, but also for social workers, other kind of mental health professionals.
Jerry,
Yeah.
and I apologize, what is DSM-5?
DSM-5, it's the Diagnostic Statistical Manual. It's kind of how we get our diagnoses. It's how insurers code their diagnoses. It's a very important, it actually makes the APA a whole lot of money. It's very important to the APA. There are changes ahead, and I won't necessarily get much into those, but it's been a really long process. Go to DSM-5.org for more details, but just as a heads up, that is coming, and we will try to bring the training to the members. CPT coding changes is something that's also very important that the APA looks at as a member benefit. What we've done is we have taken the 908 codes, and those are codes that we use, but also codes that everybody else uses. And we've now we have new codes that bring in medical judgment and medical services. So they're going to be different codes that actually pay us a little bit more money. And there's more information on the website, but 90801 goes away basically at the beginning of the year. So you're going to have to talk to Scott or talk to me or go to the website for members, and it goes through excruciating detail on that change and new coding strategies, which are oftentimes E&M codes. or you can use the 908 codes with some different specifiers. And MOC is something that I won't really go much into detail, but certainly this is going on. This continues to move forward. It is more complicated as, you know, for the folks that are coming out now or come out recently, it's much more complicated than it was even for me, or for people that are out a little bit longer than I am. This is something that you really need to be aware of, and that we're continuing to try to push back, but it's a train that's left the station, and for you guys to think that the APA has the power to stop that is crazy. I mean, it's a pushback. So we're getting, a lot of what we do is funded by the government, and this is a way for them to be able to say we have quality trained and certified physicians doing the work for us. You know, really quick, coming to the state level, as we talked about, we're going to be concerned about the ACA, insurance exchanges, and essential health benefits. One of the things that we're working on right now is a HIPAA harmonization law fix, which basically takes, we now do have, I mean, our records are very difficult for outpatient doctors to have access to. There are many hoops that patients have to go through. Oftentimes, they won't go through them because there are so many hoops, and we're looking, now HIPAA has psychiatric, has some privacy protections for psychiatry, including psychotherapy notes, ghost chart, etc. Those would continue, but what this is trying to do is this is trying to allow psychiatric records to be treated, the medical records to be treated like other medical records. Again, the way that we look at this is it prevents primary care from getting oftentimes prevents primary care from getting our records. It prevents our patients from getting the care that they need because we're not able to access their information on either edge. So this is something that we're working on right now, because if we don't, then as far as the electronic medical records, part of the joy and promise of electronic medical records is communication, everybody having information at the point of care, being able to make better decisions. If we don't make these changes, psychiatry continues to be off in the wilderness, not with the main of medicine. And at the WPA, we're again trying to push forward, continuing to make psychiatric records something completely special and different. I mean, I look at it as worsening stigma and setting us back somewhat. Now, there might have to be, folks might have to really think about what they put in a psychiatric medical record. Do you really have to put in everything in detail? No, you don't. Physician health program is something that we're working on through the WMS, and Rogers has been interested in moving this forward. Right now, a lot of us take care of impaired physicians and know that once they leave here, there really isn't a structured home for them to go to, and we're trying to resurrect the physician health program. Antipsychotics in kids is something that we've been working on too. The DHS came to us basically with an algorithm. The algorithm said, at this visit, you have to check these labs. If it's this, then you have to do this. If it's this, then you have to do this. And we pushed back against that because it really wasn't something that, I mean, that was going to be for child psychiatrists, for family practice docs, etc. And we've been having an ongoing conversation. But a few years ago, they wouldn't have come to us with this. This would have been something you guys would have noticed by having your medications denied because you didn't check this lab or this blood pressure at this time. So that's something we can talk about more. Maintenance of licensure is at the state level, something that everybody is going to be subject to if you want to continue to keep your license. Med 10, I'm not going to go into any detail about that, but they're also, the medical examining board is deciding to take a 20-year look at what our unprofessional conduct is. They've given us, at the Medical Society, they've given us about 12 pages of changes, which include things like if you don't have your medical records completed in 20 days, that gets reported to the MEB, and if you don't report it, the hospital gets in trouble. It really gets into some of our peer review processes, and we're really pushing back against that and trying to make that reasonable. There are also ways, you know, what's also in here, which I'm just going to bring up very briefly, are, you know, they want to start putting in social media. Part of what the MEB is talking about is if someone, you know, Roger, if you're caught shoplifting somewhere, you know, that would be something that they would say would make would bring shame to medicine, and you could get your license dinged for that. Not that you were doing anything necessarily with your license at that time. There are also even more punishments for folks that actually have psychiatric illness and end up making bad decisions or doing things like that. So that's something that we're really keeping an eye on. Chapter 55 and 51, there's a study group right now looking at how we can better treat patients with dementia as well as comorbid psychiatric concerns. Right now, it's very difficult to do that. A person that has dementia and is on a Chapter 55 can only be here for a very short period of time if they can come here. Most people would tell you that they can't come here. Some will say they can come here, but only for a few weeks. But we're trying to look at that and try to make sure that the patients are getting the care they need. And also the funding of the system is a big deal. I wanted to really briefly spotlight something that Rick had talked about, the Wisconsin Health Information Organization, which is an opportunity for us to look at real time, real money spent in our system. And looking at it's $29.9 billion that's spent on medical care in this state. This data is probably about a year and a half old, but it's not just Medicaid. It is commercial insurance. Actually, most of it's commercial insurance. And where do you think psychiatry shows up? Psychiatry is pretty consistently the number 3 most expensive cost center when we look at it this way. And I think that's surprising for a lot of folks, but then you also look at what else is there? Chemical dependency is certainly within our realm. You wonder how much of gastroenterology are our patients that aren't being well treated. And neurology, again, the same type of thing. So we are going to have people coming to us, talking to us about expense, and asking us to look at how the money is spent and whether we think it makes sense.
It's really interesting that again, to me, the power of this WIO data is immense. And when you look at psychiatry, to me, probably even more interesting is when you break down the various payers in the system and you look at inpatient dollars spent. And what's so interesting is that when you look at inpatient dollars spent in psychiatry and you compare the dollars that are spent or the percentage of the pie that's spent for inpatient services between Medicaid and commercial providers, what you find is that the percentage for commercial payers is about 22% of their entire pie within the WIO data mart, whereas with Medicaid, it's about 66%. And what it does for somebody like me is say, that's...
Because they pay for inpatient, they don't cover
Well,
partial,
absolutely.
they don't
Right.
cover...
Well, you guys know better than me, but the point is...
That's for our meeting in November.
Well, and absolutely, November 1st.
Yep.
Okay, yeah, and with regulatory, but to me, that's the power of this data, because you can see those aberrations, and then more importantly, organizations like the Medics, it's our job to do something about it, and just say, well, isn't that interesting?
I think, part of our job is to, because I'll tell you, if WMS wasn't at the table, again, 2 years ago, we had a secretary who was ready to start changing payment based on this. And this data isn't perfect. This data, it's nice to look at, and I think it gives you an idea of where some of the noise is, and you can go to it. But I'll tell you, this is why the state is very interested in us. Medicaid, a lot of their funding goes to psychiatric care, so we are going to continue to have conversations with the state. And taking a look at those numbers, just to give you kind of a generic idea, when you go at specific diseases, psychiatry, like psychiatrist pay is usually between 6% and 8% of that number. So not that Medicaid really pays anything for psychiatry right now, but certainly we don't have to look at payment cuts for Medicaid for providers, because that's not really where the money is. Again, where the money is are meds, and that's why we're talking about antipsychotics in kids, although I think that's a really small part of the big picture, but they decided to talk about antipsychotics in kids. And and some of the other things like inpatient. But again, ultimately, if you don't have a partial program or a residential program to send these people, they are going to sit on inpatient for a longer period of time. And I think that's part of the conversation that we'll continue to have with these folks, trying to right size and have the payment kind of go where it should go. And, you know, obviously cardiology and orthopedics, you know, we have our patients are certainly up in there. So what's ahead? I'm just gonna wrap up here real quickly and we'll have 15 minutes for Q&A. Funding of psychiatric care will continue to be an issue, whether it's single payer versus multiple payers. I know a lot of folks are really pro single payer right now. If it was Medicare for all, that would not be good for the for psychiatrists or for hospitals or for anybody right now, frankly. Versus the multiple payers that we have, which continues to be very confusing and certainly isn't the best answer either. And then quality versus a per service. Quality, we need to continue to help define what exactly quality is. Right now, we're defining quality as, at the first visit, did you ask somebody about suicidal ideation? Which, you know, a psychiatrist, obviously we should be doing that, and in these settings, I'm sure we do that. But those are the types of things that are quality right now, and you know, obviously we're gonna have to do better moving forward. Workforce is gonna continue to be an issue. You know, we can talk about medical college in Wisconsin, opening a medical school up north, but if we don't have enough residency slots, it's not going to matter. As we have more, again, I think workforce is going to be a big issue because even as we have more medical students, there's going to be a higher competition for let's just go to psychiatric slots. And frankly, we have used international medical grads. They've had to go and go to underserved areas for a few years. And that's really how we've had a lot of underserved areas treated by good docs that had to go there. As there are more US grads, there are going to be less slots for international grads. And US grads are going to be just as unlikely as you and I to go up north. So the rural issue is going to continue to be a big problem. And we're looking at things like telepsychiatry, et cetera, but that's going to be a big issue moving forward because that leads to the scope issues. And you know, since you guys aren't able to cover these patients, you know, we want someone to come in there, but then, you know, when folks don't have the medical training, it becomes very concerning. And the role of psychiatrists is something that we're really going to have to struggle with. I was at an APA meeting 3 weeks ago, and a lot of the conversation was, you know, the way that the ACA wants us to practice, meaning integrated or in a psychiatric medical home, is not a practice that I think 90% of psychiatrists have any interest in whatsoever. So I think that's going to be interesting to see how that works out. The other piece is, are we going to be taking care of the patients that we're taking care of right now, or are psychiatrists only going to see the really sick patients? Because that's not what happens right now. I think it happens on the inpatient unit, obviously, and it happens at partial level of cares, but a lot of psychiatrists out there aren't taking care of the sickest patients. Or are we going to be doing more supervision of PAs, NPs, etc.? And what is the best way to use the limited resource of psychiatry? And that's not a practice that I think a lot of you guys went into psychiatry for, so it's going to be interesting to see how we do that. And I think that's why it's important that, especially at this time, where we're figuring out the healthcare system for the next 20 years, physicians have to be active and physicians have to help chart the path. People are listening. We're at the right tables, but we need people to care enough to be active. Then we also talked about privacy concerns and WISHIN. So recent successes, you know, I guess whether, you know, the AMA support of healthcare reform, I think, cost the AMA as many members as it's gained, if not more members lost. But I think in general, psychiatrists are more happy with that. Parity, I'll tell you, AMA wouldn't have been supportive of parity if the APA wouldn't have been there and been pushing it for so long. It was a lot of work. But AMA supporting parity helped parity work. I hear people say, you know, AMA hasn't done anything for me or my patients. I think parity, getting the national parity law was huge, and AMA played a huge role in that. Scope of practice will continue to be a concern. Antipsychotics in children, you know, as I said, we really helped prevent a really difficult, onerous practice, practice slowing down piece of possible legislation, but that will probably come back. Med 10, we're trying to make more reasonable, and I always want to continue to remind people about what Medical Society did with the Injured Patient Compensation Fund, and how the Medical Society really unilaterally prevented our malpractice climate from getting a lot more unreasonable, and that was, your medical society, your dues. So how you can be more involved? You're already a member of your county medical society. If you're in Waukesha, they have very nice meetings a few times a year. They don't have monthly meetings, but you're certainly welcome to go to that. Milwaukee has monthly meetings that you could go to. And also, you could join the AMA and the APA. Those are not something that Rogers pays for unless you ask them to, and it comes out of your fund. And I do want to tell you a little bit, a couple plugs. APA annual, or the WM, lots of acronyms, guys. The WPA annual meeting in Madison in March. We're going to have a lot of folks talking about some of the future-oriented pieces that we're discussing here. John Oldham, our immediate past president, is going to talk about DSM-5 as well as integrated care models in Texas. We're going to have Jeremy Lazarus, who's a psychiatrist and current president of the AMA, which is the first psychiatrist president of the AMA in a long time. He actually was from Wisconsin. He ran, I think, what was probably a forerunner of county or something along those lines many years ago. David Katzelnick will be talking about some new models in Minnesota. There's a pediatric consultation model that I think most people find interesting, otherwise it's integrated care. Bob Golden, a psychiatrist, dean of the medical school in Madison, is going to talk about the future of academic psychiatry. Andy Pomerantz, the head of integrated care of the VA, will also talk about medications. Yeah, maybe you know him.
Andy's great.
Yeah. Justin really pushed him. And Steve Brandon, we're going to have a vice president at a pharma firm is going to come in and talk to us about the pipeline and kind of what's going on with the pipeline. And we're also going to have Pat and Bill do a talk on the business of psychiatry. So we'll have some Rogers-centric folks there, and we'll have some resident vignettes, which will be fun, and you can look at that, look for more information on that coming up. And then we will have an WPA Advocacy Day, which will be the day before, and we would certainly encourage people to come with us and do some legislative advocacy. This is going to be right around budget time, so we're going to be talking, I think, a lot about making sure that we at least keep the status quo. I think is going to be our piece. Okay, and then that was actually a little bit longer than I wanted it to be, but I think gives you guys an idea of everything that's going on out there. There's a lot going on out there, and we're doing a lot of work on your behalf. So I think do you have any comments or questions?
No, Jerry, that was a very, very comprehensive presentation. And the only other issue that I would mention at the state level, and really it's the number one issue at the state level for the medical society, is that just when I came on board in the end of April, the Wisconsin Supreme Court issued a decision called Genre. And basically what that decision did was turn the whole concept or principle of informed consent on its ear. And essentially what the Supreme Court did by the barest majority was basically broaden the duty of a physician not only to counsel your patient on what you've diagnosed him or her with, but also on those diagnoses that you've ruled out and any of the tests that could be provided on those ruled out diagnoses. So essentially what the Genre decision has done is that it is just eviscerated the whole concept, made it very, very broad, and they compounded their error, in our estimation, by not giving physicians any kind of a roadmap as to where your duty of informed consent begins and where it ends. So the number one priority for the medical society is essentially to pass legislation that would effectively overrule that decision and at least return the concept back to the way that it is couched within the statute. The second area, and Jerry, you talked about Medicaid a lot, is that certainly we want to make sure from a financing standpoint that we don't lose ground. In the last budget cycle, Governor Walker injected $1.2 billion into the Medicaid budget. Again, we want to make sure that there's not any slippage. In fact, if at all possible, we would like to see funding enhanced for Medicaid. The Medicaid program was the only program in the state budget that got an increase in budget. But in the Medicaid area, the second thing that we're really going to focus on, and again, Jerry alluded to a meeting that we're going to have with the Medicaid administrator on November 1st, is really to take a look at regulatory reform and really be able to isolate, not anecdotes, but isolate specific Medicaid regulations to the to Administrator Davis, and basically say, you know, Administrator, these have been on the books for a while. They're all about bureaucracy. They have nothing at all to do with reducing cost and enhancing quality. And you know, we're here to ask you, or ask, if you will, is to either modify it or to repeal it. And at this point, we're putting together a meeting of it. I mean, my original guest list was about 30. At this point, we've got about 8 people attending both in person and on the phone. And again, the goal, the meeting will only be effective if we can provide specific examples for the administrator, and it'll be the first of many meetings. So that's all I have to add. On the
I
federal
can't believe I
side,
didn't, yeah, SGR.
yeah, but you included so much. You know, on the federal side, no, Jerry, actually, you did talk about the sustainable growth rate formula. Look, folks, Congress is not going to cut Medicare rates by 32%, because they know what will be knocking on their doors within 30 days, and that is their constituents. So they're not going to do that. What they are going to do is that, especially with the election, regardless of the result, they're going to kick the proverbial can down the road a little bit more, 3 to 6 months. What we in Wisconsin, but I think more importantly the AMA and some of the national organizations are working on, is not just to repeal the sustainable growth rate formula, because frankly the likelihood that that's going to happen isn't likely, because the cost of repeal is about $300 billion. But what they're
That
advocating
physicians
for,
owe the government.
right, yeah, right. But what they're advocating for is they say, look, in order to transition into a new Medicare payment system, you do need to provide some stability and some predictability for not only physicians, but you know, we forget that the sustainable growth rate formula applies to every Part B provider of care, not just physicians. So the chiropractors, the podiatrists, the nurses, everybody is impacted upon on the uncertainty. So what we're trying to do is we're not only saying, look, you've got to address this issue to provide some stability and predictability moving out. But what we're also saying, and especially doing a good job on this in Wisconsin, talking about things like value modifier, is being able to transition to a better place in 3 to 5 to 7 years. But the last thing I'll say about the federal environment is that, you know, it's not just about sustainable growth rate formula. When you look at all of the issues that the Congress has to deal with, if not in lame duck, early next year, I mean, it is just mesmerizing, because it's not just the 32% or the 30% SGR cut. It is the fiscal cliff that came about on the deficit reduction and debt ceiling deal that they worked out last year. Effective January 1, everything is going to, unless Congress acts differently, everything is going to be cut across the board by 2%. What that means for healthcare is an $11 billion cut in 2013, but over the next 10 years, 41 billion. I mean, you've got other things like the tax cuts that President Bush put into effect, the sunset of long-term care unemployment benefits, the sunset of the 2% reduction in Social Security taxes. You put all of those things together, if Congress doesn't act, that would actually cut the federal deficit, which in 2013 is projected to be $1.2 trillion. It would actually pretty much cut it by 60%. The other thing that would happen is that the Congress let all of these things sunset, including a 32% and allowed a 32% cut to take place in the Medicare fee schedule. What economists unanimously, whether they're Democrat or Republican, say is that if the Congress ever allowed all of these things to happen, which would actually save $641 billion, what would also happen is the most serious recession, if not depression, that would occur, that would make what we went through in 2009 look like a cakewalk. So those are the big issues that just swirl around DC. But thank you very much. It's been great. That was a great presentation.
Questions or comments? I know I just spit out a whole lot of information. Jill. But again, I think, obviously, you have an opportunity to talk to either one of us. That might be a little bit easier accessible as I'm in Oconomowoc part of the time. But we can certainly talk about this more. Any of these, I can go into much more detail than I did.
And Jerry, too, I mean, like I say, I'm here today just to introduce myself, but, and we talked about this before, and Jerry knows that anything, we're here to be of service to you all. So literally, whether you have questions, we've got a staff there that's in Madison that's happy to help you. You've got the county medical societies, but, this location, or for that matter, the Milwaukee location, I mean, we're not talking about, like when I was in New York, when I would travel from Albany to Buffalo. I mean, we're not talking about that. So my point is that if I'm not the right person, certainly we can have the right person, whether it's in our legal counsel, our practice management, our governmental affairs, our membership, whatever, our CMA, whatever you need. I mean, because, we want to serve you, and because if we don't provide value to our physicians, your organization's not going to join our organization, and that would not be a good thing, especially given the unique role that you have in the healthcare continuum here. So thank you.
Okay. Thanks, guys. Thanks, everybody.
Thank you.
Thank you.
Thank you.